So we have seen from the research that poor sleep is more predictive of worsening pain than worsening pain is of poor sleep. When we know that there are solutions to improving your sleep, there are research-backed protocols, there are treatment plans, there are ways to improve your sleep so that you don't have such a strong impact from the poor sleep. My name is Dr. Medalie. I'm the founder and CEO of Dr. Lullaby. I'm a behavioral sleep medicine specialist. And today, what I want to try to do is instill some hope that there is a lot that we know about the relationship between sleep and pain. And there is a lot we know about how and where to focus your time and energy to get the most relief in this relationship. All right, so to kick us off, let's go ahead and talk about the science of sleep and how pain impacts sleep. So I love to talk about this because something that most people don't know is that we sleep in cycles and wake-ups are part of sleep. So in particular, a lot of times our chronic pain patients, they tend to have a little bit lighter sleep and more frequent wake-ups. And so anytime there's a wake-up, it's really, really frustrating. And then there's a fear about, oh my gosh, I'm not going to return to sleep. I woke up, this is bad, here we go again, here's another night like this. And so I want to assure you, most people wake up during the night. Wake-ups are part of sleep. So I myself wake up 2 to 3 times during the night. I wake up, use the restroom, lay back down, return to sleep. It's about a 5-minute wake-up. And the reason is because we sleep in cycles. And so we start off in stage 1, and then we go into stage 2, then we go into stage 3 when we have those big delta wave, slow wave sleep, back into stage 2, and then into rapid eye movement sleep when we have more vivid dreams. And then the cycle completes and we start it all over again. Now, when you complete a 90 to 120 minute sleep cycle, usually your brain waves shift from a stage of sleep into a stage of wake. So have that for about 3 seconds. And so if it's 3 seconds and your bladder's not full and there is no pain sensors that are red flagging you to wake up and take care of the pain, you might just turn your head and then return to sleep and start another sleep cycle. And you might not even remember that 3-second cortical arousal the next day. So some people say, I never used to wake up. It didn't start until the pain started. And I will tell you this, you did always, you're always waking up. We all always wake up during sleep. It's just part of how sleep works. So from now on moving forward, I want to just help you guys to reshift your mindset so that when you complete a sleep cycle, you can then say, I woke up, that's okay. I learned wake-ups are part of sleep. This is not a bad thing. Because if the reverse happens and you're like, oh no, this is bad. I just woke up. This is a problem. I'm never going to fall back. You're pathologizing the wake-up and then you're having a stress response. Your body goes into fight or flight mode, and you're much less likely to have success with return to sleep. I do really want you guys to understand how pain impacts sleep. You know it impacts sleep, and here's the why. It is really hard to get good quality sleep when you're dealing with chronic pain. I'm going to tell you this as sort of like, it's kind of like bad news, good news. It is true. I'm just validating for you right now, and I'm not telling you anything you don't know, that it is really hard to come by adequate sleep quality because pain, when your body is experiencing pain, it is signaling to the brain that something's wrong. And that even if you're asleep, it is trying to support your wellness overall. So while you're asleep, you're going to have more of that lighter sleep, that stage 1 sleep. You're going to have less of the slow wave sleep, that deepest stage of sleep. And the reason is because when you're going towards, remember we talked about going in that cycle, when you're going towards stage 2 sleep, you're going to end up having what we call sleep stage shifts. We can also refer to these as alpha intrusion or microarousals, sleep fragmentation, right? You're moved, kicked out from the deeper stages, from stage 2, from stage 3 back into 1, because it's an alert, it's a signal. Your body's doing what it's supposed to and telling your brain something's wrong. And so that's the essence of what's going on and why we always hear our pain patients complain about sleep quality. And then, we just tend to see that our pain patients, as a result of having poor sleep quality to begin with, they tend to have this just more fatigue, increased fatigue, which I don't have to tell this audience that you all know and are likely experiencing fatigue. And I want you to understand a little bit about the why. And because of this, when us sleep specialists see a pain patient and they have insomnia, they say, it's taking me a really long time to fall asleep, which is so very common. I'm having prolonged nighttime awakenings. I'm waking up in pain and it's taking me a long time to return to sleep. Is very, very common. So when we see these patients have complaints like this, we know that it is very likely, I'm going to get into this in a bit too, that we can actually help them here. We can improve their insomnia. We see incredible results with our pain patients too. And we can reduce their insomnia symptoms, increase their total sleep time if it's relevant, and have them falling asleep and returning to sleep faster, even with the chronic pain. The fascinating thing about the pain and sleep relationship is that there is this bidirectional relationship. So we know that the worse your sleep is, the higher your sensitivity to the pain, the increased experience you have, the increased inflammation that you experience, and the harder it is to inhibit the pain response. And so that's why we talk so much about the value and importance of improving your sleep for every pain patient. So what's been really interesting to learn from the research is, while there's a bidirectional relationship, there's a direction of the relationship that is stronger. So we have seen from the research that poor sleep is more predictive of worsening pain than worsening pain is of poor sleep. Now, of course, we still know that worse pain is going to predict poor sleep. It's just that the poor sleep is the bigger culprit. And the power of that to empower you and get you excited about that news in a way, maybe excited is the wrong word, but to feel strength from that finding, and we know that there are solutions to improving your sleep. There are research-backed protocols, there are treatment plans, there are ways to improve your sleep so that you don't have such a strong impact from the poor sleep. And so I wanted to get to a couple of things that you can honestly start with tonight. Whenever I'm speaking to audiences in 2026, it's like everybody knows kind of the basics, right? And where I want to focus for this group, though, is really about the two things that I think you can do that might move the needle the most and that you could start tonight. One is calming your body. If you can take the 1 hour before bedtime, and this really does start with giving yourself an assigned bedtime, because what is the 1 hour before bedtime if you're just going to bed whenever you want to go to bed? We do always say it's extremely important for all people, even if you're not a chronic pain patient, all people in general, even myself. I don't have insomnia per se. I just go to bed, wake up at the same time every day, because I know that optimizes my sleep, that optimizes my energy level, my brain function, my health, my mood, my relationships. Everything feels better when I keep a consistent sleep window, because it's entraining my circadian rhythm, it's teaching my body when to be awake, when to be asleep, and it's optimizing my sleep pressure buildups. And so when it comes to our chronic pain patients, what you do during the hour before bedtime also needs to target pain. It is ideal if you have pain support and pain relief during that hour before bedtime. That way, everything's kind of calmed down a little bit. And that in itself will help to support improvement of both insomnia and sleep quality. Our general rule of thumb is typically a nice hot bath or a hot shower. Epsom salt, a lot of our pain patients do. So a nice hot bath and some soft music and some light reading during that hour before bedtime is a beautiful thing. So you want to pick 2 or 3 things that are the most important to you when it comes to pain support and calming your minds and your body. That's something that I think can be extremely helpful to get into the habit of. And even if it's the same genre of music, every night we talk about this for the babies and the pediatric sleep, where we always tell our parents to pick one song and play it on repeat during the hour before bedtime. I also think that can't be a bad idea for adults, because you get used to it, even if it's the genre, right? I take Enya baths. I love Enya. So that's the station that I listen to during my pre-sleep ritual. It's not that I'm listening to the same exact song, but that's the genre because it trains my mindset. It's classical conditioning and paired associations. My brain knows when Enya comes on, there's just an instant calmed response to that. And it's been repeated night after night, so that repeated pairing really trains your brain to expect and to go into a state of calm. Then there's this issue of protecting your space. Turn off your cell phone, your tablet, your laptop. And the reason is twofold. It is about the light that projects from the screen so close to your face. And it's also that blue spectrum light. We still do believe in that. That blue spectrum light is telling the brain to stop producing melatonin, and ideally you want that pouring of melatonin to support sleep onset. It's also, though, and maybe even more importantly, the engagement that's happening from those devices that really sets you into fight or flight mode. So you texted somebody. What did they text back? How do you feel about what they texted back? What's your response there? There's an emotional reaction. There's a stress response. Social media, someone posted this, I want to post that. There's an emotional response, there's emotional engagement, there's relational triggers that are happening there. Email, my boss texted this, and my boss sent an email about this, and I'm going to respond that, right? All of these things in the digital world, relational elements are a no-no from my standpoint. I think we just want to stop the human interaction on the digital side and the in-person side. So family, if you live with a spouse and kids, it's like we really need to make it clear that the hour before bedtime should be me time. That should be their time to just, close the door to the bathroom and count it as they should think of you as asleep already. So on the other side of the fence, there's also just, what does help to alleviate the chronic pain? And when you look at the research, it's really interesting to see that CBT-I actually does come up across the board. So cognitive behavioral treatment for insomnia, meaning if you just treat the insomnia, that in itself is so supportive of reduced pain. So that's really lovely to see. And then exercise as well is considered to be one of the best first-line pain treatments. Just for reducing inflammation, and that in itself is helpful and supportive with sleep. And then, doing stretching, walking, and yoga. And these are also coming up across the board in the literature as supportive for pain reduction as well as being supportive for sleep. And then kind of combining these movement approaches as with sleep tools are, really helpful and powerful as well when we see from the research what is truly evidence-based and then actually moving the needle with actual management of pain to improve your pain and then thereby improving your sleep. So we see all the time people can have a diagnosis of chronic pain and comorbid chronic insomnia. And what the research really does show is when it comes to chronic insomnia, the American Academy of Sleep Medicine, the American College of Physicians, NIH, they all recommend cognitive behavioral treatment for insomnia as the first-line treatment. And actually, it's not medication. All of the research says that it should be CBT-I first, and only if you fail CBT, only if it doesn't work well for you, then should a sleeping pill be tried. So another thing to really screen for, be aware of, is sleep apnea. So sleep apnea is a breathing disorder. So during the night, the hallmark symptom of sleep apnea is loud snoring that you can hear outside the bedroom. And you don't always have to hear the pauses. If somebody is just loud snoring and sleepy during the day, those two symptoms in themselves are enough to warrant a sleep study most of the time. But we do typically see that when someone has loud snoring and excessive daytime sleepiness, especially if they also have chronic pain, I'd love to see them get a sleep study because we would like to not miss anything. If you have untreated sleep apnea and chronic pain, we see the research actually shows that those who have those symptoms are often more likely to complain about insomnia as well, and they're going to have more of an impact on their pain symptoms. So it does become really important to catch this possible sleep apnea, check it, and treat it. Let's talk a bit more about what is cognitive behavioral treatment for insomnia. So like I mentioned when I first introduced myself, I'm a behavioral sleep medicine specialist. And so my whole career and specialty area, my whole team, all we do is focus on insomnia management and special unique types of insomnia management. So there is this formal protocol of using sleep hygiene, sleep restriction, stimulus control, relaxations training, cognitive restructuring. It's usually about 5 to 8 sessions, the protocol itself. And what you do is you're filling in sleep logs while you're working with a clinician, and they're analyzing your data. They're able to see from your data what kind of sleep window is going to make the most sense for you. They're making recommendations about how to deal with the fatigue. So there's customized care, a lot of times really helpful for chronic pain patients because they're tired during the day. And if they have a flare-up and they're in a lot of pain, normally insomnia patients, we say don't take a nap. But with pain patients, we kind of let them off the hook. We tell them try to rest instead of nap if you can, because if you take a nap, it does impact your body's urge for sleep at bedtime the next night, and you're more likely to have more insomnia that next night. That being said, we make exceptions for our pain patients because we know how hard it is to avoid naps when you're in pain. So we also are a little bit more gentle on what we call sleep restriction. Sleep restriction is when a sleep clinician analyzes your sleep data and they say, okay, during your baseline logs, you were in bed 9 hours on average, but you were only sleeping 6 hours. So based on that and your circadian tendencies, I'm going to assign you a sleep window of 12 to 6. And then if you have chronic pain, we might be a little bit more gentle. So we might maybe do 12 to 7. You make it a little bit easier because we don't want too much sleep restriction for a pain patient. Sometimes that can cause flare-ups, so you kind of have to figure out what makes sense for which patient and work together to get the best possible starting off point. And then you gradually increase that sleep window to get to the ideal sleep window while you're working on other techniques and strategies. And again, always, always, always alongside pain management, care team support. So one of the big things you might have read online to try to, get out of bed if you're not sleeping, which is definitely something that behavioral sleep medicine specialists preach about. We don't want you laying in bed in pain, frustrated with your pain, stressed out by your pain, saying, why am I having this? Why is this happening to me? All of that experience, associating your bed with those negative thoughts, with that pain experience, with that stress response, it's teaching your brain to associate the bed with negative thoughts, pain experience, and stress response. So it's night after night after night. Ultimately, when you get into bed, you can kind of go right into that state. Your brain says, oh, I know what we do here in this bed. We go into pain mode. We go into a stress response. We feel anxious and stressed. So that is something that we really try to work on breaking. And then relaxation strategies. So these also are if you search in the Curable app, you're going to be able to find some really good relaxation strategies. We tend to like diaphragmatic breathing, positive imagery, and progressive muscle relaxation. So you should be able to look for deep breathing, imagery, muscle relaxation, and really get some great tools to try. And again, you can even start with using those tonight just to kind of, even in your pre-sleep ritual, just to get your body, get yourself physiologically in the best, most calm state before sleep. And then, we work on just getting your mindset into the right place because we do tend to see that when patients have chronic insomnia and chronic pain, there can be this sense of hopelessness, this sense of helplessness. Oh my gosh, I'm never going to sleep again. And I'll show you an example here of, this was one of our just insomnia patients that, they're triggering moments. They wake up, they're thinking during the day about their insomnia from last night. And their thought that they're having, that negative thought is, oh, I'm never going to sleep again. And they're feeling anxious in response to that negative thought. And then we work through with the clinician, like, what are the facts that support that statement is true, that I'm never going to sleep again? How true is that? Let's just get down to the bare facts here. Well, 2 nights last week, it did take me 1 hour to return to sleep. And 40% of the last 6 months, I did have 3 weeks of insomnia, right? We're just being super factual and just looking at the data. And what are the facts that dispute the accuracy of this direct statement? Well, 5 nights last week, I fell asleep and returned to sleep in 20 minutes. In 60% of the last 6 months, I had no insomnia. And the first 10 years of my life, before the pain started, I had no insomnia. So the replacement thought might be something like this: I'm doing my best to improve my sleep and completing the first-line treatment protocol. So even if I continue to have some poor nights, I am grateful that this is the worst of my problems. So then it's like, maybe it doesn't get rid of the anxiety completely. You might still feel anxious thinking about last night's insomnia. It's just that from a more level head, from a more balanced replacement thought, you're able to think in a less fortune-telling, overgeneralized, over-negative way. Because we don't want to just sugarcoat it and say sleep is perfect right now. We also just don't want to go to the other extreme and say that it's so terrible that you are never going to get past this, because that's not true either. So we kind of come up with ways to get more balanced in your thinking. With a behavioral sleep medicine specialist, our approach is usually to make sure that there's a great modification, knowing what a chronic pain patient goes through. Like I said, it's behavioral sleep specialists see so many pain patients. Like, it's just a very, very common thing. And so we try, like I was telling you, if we're not necessarily being as extreme when it comes to setting the sleep window. We don't do too much sleep restriction. So that's one of the big modifications we make. We do try to, normally we are very strict with nap avoidance. We do sort of allow for rest time, and we're gentler if you need to take a nap. We try to ask our chronic pain patients to track pain as well as sleep. So when we have sleep logs filled out, we want every day also in the morning when they're filling out their sleep from the night before for them to rate on a scale of 1 to 10, how bad was your pain, so that we can track and see the correlates there. And just that catastrophic thinking about pain and sleep. It is so important to get control over your mindset, to make sure that you are very clear about how overgeneralized thinking and catastrophic thinking about your pain, about your sleep, is actually making things so much worse. So trying to get into this new, healthier, empowered mindset that there is so much I can do. The research is showing there is so much hope for me. That's the kind of mindset that we want to have. And shifting that mindset will directly already help with both things. Key action steps, just understanding the connection that we were talking about, that pain and sleep and pain fuel each other. Really working on that hour before bedtime, calming your body, protecting your space and your me time, making sure that you always stay proactive with your pain management approach, whatever it is that is best in class for you and your unique pain situation, and tracking, using data to inform your decisions, see what's working, see what's not. Making sure you're screening for more clinical conditions. A lot of people that have sort of mild sleep issues, and I think if you're just more on the mild side, just make sure that you're searching and optimizing your sleep on your own. Make sure you're looking up the Curable app has these relaxation strategy tools that are really great. So make sure you look in the app, search the app for these different tools and techniques. And then, knowing that CBT for insomnia, it actually helps not just with the insomnia, but also has results with the pain.